Our didactic today is being presented by Dr. Ann Loeffler, who, as I said, is a TB luminary. She has a very brief bio that she submitted that doesn't really do her justice, but she is a pediatric infectious disease doctor. She's been a Curry Center pediatric TB consultant for 25 years, and she's currently the TB controller in Santa Clara County, California. Before the session, she just let us know that she's about to have her 30th wedding anniversary, and she's off to the Cayman Islands soon to go scuba diving. So in addition to being a TB luminary, she lives a pretty cool life. Take it away, Ann.
Well, thank you for that introduction. So some of you might remember a little handful of weeks ago, we were talking about infection control and kind of the policies and the way it works in the hospital. And it really addressed the adult hospital. Pediatric children and adults are very different in terms of their risk of contagion with tuberculosis. So as I like to do, threw some things in the chat, just trying to teach and whatnot. And so be careful when you do that because you might be asked to make a presentation. But before I start, I do want to recognize the pediatric infectious disease and infection control team from Seattle Children's who are also on this call, and we'll be looking for their input a little bit later on. Next slide, please. So these are the objectives, basically to kind of explore the mechanisms of TB infectiousness so you can think about why you would try to avoid unnecessarily limiting patients if they might not be contagious. I'll just do a little public service announcement, and that is to say that there's good data that if you do excessive isolation or precautions, as we like to call them, and use PPE, maybe unnecessarily, that there's good data that healthcare workers go into patients' rooms less and they give less care to patients. And that is really, really unfortunate that that happens. So we want to right size all those kinds of infection control policies and procedures that we use. And then my second objective is just to show you some of the policies that some of my friends use, especially around the West Coast in terms of their infection control in children's hospital settings. Next slide, please. In case you don't take care of children every day with tuberculosis, I wanted to just kind of expose you to what their intrathoracic TB disease might look like. Oftentimes kids have infiltrates or consolidations in the parenchyma. I also call that airspace disease just to be a little bit vague about it, but includes the alveoli and the parenchyma. But they also have a lot of enlarged lymph nodes in their chest. And sometimes you don't see that on a plain film, but if you did a CT scan on all kids and you did it with contrast, some of the literature suggests that up to 90% of kids diagnosed with TB disease will have enlarged lymph nodes seen. Now, you can obviously everybody has lymph nodes in their chest, and but you want to really take caution to identify those that are enlarged. Oftentimes, they look like what I call inhomogeneous. So they look a little patchy. They don't look smooth and gray. They look like there's a little darkness in them. And again, a kind of a patchy appearance. And that's because those lymph nodes are frequently in the active state of necrosing. And in the pediatric plain films, I like to remind people to always get a 2-view chest radiograph. What the national guideline says is if your program cannot afford a 2-view chest radiograph for all children, at least for sure prioritize those kids under 7 years of age. And the reason that is because in California, for the 10 years before we wrote that guideline, we looked at the RVCT submissions and found that age group was most likely to have submitted on the RVCT that they had intrathoracic lymph nodes. So mediastinal and hilar lymph nodes would be very difficult to distinguish on a frontal view. But if you're questioning whether there's some fullness in that area, then you look at the lateral view and you see that density oftentimes in the infrahilar window. But then paratracheal lymph nodes, you really don't see on the lateral view. And what you're looking for is on the right side of the upper mediastinum adjacent to the vertebral bodies. You might see some fullness, and then oftentimes you'll see that the airway, if it's a well-positioned child, you'll see that the airway is either in the center or a little bit over to the right. That's the signal to suggest that you have a paratracheal lymph node. Because if a child is really symmetrical, it's not rotated on that chest film, the normal airway will look a little bit to the left. And I don't know if that's because where the aorta is, but that's how I remember it. Just thinking the aorta is over there on the left, and so the airway winds up being a little bit over on the right. And then subcarinal lymph nodes, you're really in the cool kid category. If you say, "Oh, look at that subcarinal lymph node," and the way that you tell that is that the airway is splayed. Normally you have that appearance where the right main stem bronchus is going down, not straight down, obviously, but more straight than the left, and then the left is more at an angle. And when you see that they're more splayed out, you go, "Oh yeah, that's so cool." And then they pay you more. No, pediatric infectious disease doctors do not get paid a lot of money, so don't bother to do it for the pay. Children, sometimes when they have extensive disease or when the lymph node has eroded into the airway, they start to spew that caseous material into the airway. That's what we call endobronchial disease. You really only can make that diagnosis of endobronchial if you have a scope down there and you see the spewing of the disgusting stuff. Sometimes what happens, though, is that the kids maybe will have been seeming like they were getting a little bit better on TB therapy, and then they start coughing a lot again. And the family sometimes will tell you that they're coughing up this caseous stuff. It's pretty disgusting. When that caseous stuff is actually also sending live organisms in the airway, it can actually go up into the level of the carina. Obviously, they can cough it up, they can throw it up, but it also can go down the other side. So sometimes when you see the bigger patches in different parts of the lung, that's because the material has caused what we call bronchogenic spread. And then another little phenomenon that can happen is that you get what's called collapse consolidation. So the lymph node compresses the airway to the point where then you get lung collapse, and you also get parenchymal infection. Sometimes you get what I call a post-obstructive pneumonia, because sometimes the bacteria from the mouth get into the airway. That happens every day of the week, right? That happens to all of us all the time, but our cilia and our immune system kind of beat it up and tramp it down. But when you have extensive disease like that, sometimes the mouth flora gets trapped behind the compression of the lymph nodes. So anyway, I just thought I had to spend some time, because there's not a lot to teach here about this infection control thing. But just you might notice that what I don't have on there is cavities. So children seldom get cavitary disease. Most of what you see is due to the immune response. The immune system is fighting these infections. It makes the parenchymal changes. It causes the enlargement of the lymph nodes. It causes that rupture into the airway, but it's not a lot of organisms. So again, cool kids say paucibacillary, Pauciba, you know what I'm saying, paucibacillary, they have few organisms. Next slide, please. So this is the cavitary disease being uncommon is really kind of in the young children. When you start to get more into adolescence, so I'm going to show you an extreme example where a somewhat younger kid had cavitary disease, but usually we think of kind of adolescence. So maybe in the 12 years of age, but definitely teenagers can look just like adults. They can have more of reactivation disease rather than a primary or post-primary, or early post-primary, I should say. So definitely those kids, you have to consider them to be contagious. And I mentioned already that the kid's disease is paucibacillary, but the other thing is that the people think they just don't have those big, strong coughs that lead to the expulsion of the organisms out through the airway and into the air. So our rule is children are generally not contagious with TB disease, except when they are. Next slide, please. So this is, oh, I'm embarrassed that I did not put this reference, but this is a famous case that was published in the New England Journal when I was a younger doctor, and there was a 9-year-old boy from the Marshalls. I'm sorry, I'm probably triggering people here, but he wound up in North Dakota, and he was diagnosed with bilateral cavitary TB. So again, younger than we like to think about, but it definitely can happen. And come to learn that both his twin and his guardian both wound up with TB disease. The guardian's disease was not to the extent that anyone would have ever expected her to be contagious. So they did a broader contact investigation. And can you even believe it? They found 56 contacts from a 9-year-old had converted their tuberculin skin test. And at that time, they were using induration of at least 10 millimeters. I think we're more used to using 5 millimeters as a cut point for when patients have a known exposure. Three of the four household members were infected, and just a super high number of other people. So that is very, very unusual. But again, I do want to say it can happen. So you definitely have to know that. And the other big exception, next slide, please, is the very strange phenomenon of congenital TB. And this is where Chandler and I became friends over congenital TB. I think I've earned the happy hour, by the way. But this was a crazy thing that a handful of, well, I guess more than a handful of years ago, you know, a while ago, people started to make this recognition that there were these cases of congenital TB that transmitted to healthcare workers. And there was one situation where a second baby in that nursery setting was infected. Now, one of the sort of bigger investigations was they came to decide that it actually was associated with the bronchoscopy. So that's a little bit different. But definitely the healthcare workers that became infected were more the individuals who worked with those babies during aerosol generating procedures. So back in the day, we didn't always use inline suctioning, is what we call it, where where the tubing from a ventilator to a trach or an endotracheal tube, it used to be that we would open that tubing every single time we'd suction a baby. And in these unusual but documented cases where healthcare workers were infected, it was more often those kinds of settings where you would expect aerosols to be generated. Now, interestingly, one of the things that we always talk about with a marker for likelihood of contagion in adults is smear status. So, if you're smear positive, it means you have at least 10 to the fifth organisms per mil-ish of sputum. And kids, even if you do well done sputum induction or gastric aspirates in those young kids, you will essentially never get a smear positive. But young infants, like the first patient I ever took care of in my life with tuberculosis was a baby with congenital TB, and they had smear positive gastric aspirates. So that's like a little cue that maybe there'd be this risk of contagion. And sure enough, it is a thing. Next slide, please. So again, in pediatrics, we would think of an increased risk of transmission. Again, in general, we like to say young children are not contagious. But of course, if you had very extensive or cavitary disease, you're going to ask yourself, could that child be contagious? If you have laryngeal TB, which I've never seen in a child, but we know laryngeal TB increases the risk of transmission. If the child is undergoing aerosol generating procedures, again, of course, if they're adolescent or a teen, or if a newborn. So all those categories would make you think, oh, I wonder if this kid could be contagious. Next slide, please. So I pulled these things out because I think Lana K. Dove is amazing. And I found these references in the 2005 guidance, which is right now kind of all we have. And it has several places where it mentions children. So I won't read these things, but the first quote basically suggests that you should think about these kids the same way you're thinking about adults. So if you had extensive or cavitary disease, or if for some reason you already had smear status, you're going to consider that kid to be contagious. But that in kids who have the more typical primary TB lesions, which might be parenchymal disease, it might be the Gowen complex, those kids may never need to be in an isolation room. Next slide, please. So this guidance says that gastric aspirates do not necessarily need to be done in airborne precautions, but don't perform in an area in which persons infected with HIV might be exposed. I would just say that it has been my policy and my practice throughout my career to always do gastric aspirates in a negative pressure room. Those kids can get to coughing and screaming pretty good, and they're kind of right in your face, and their parents are there with them. And the last thing from this guidance is that because the source case for pediatric patient might be a member of the infected child's family, you should think about that possibility for all parents and all visitors of hospitalized children when you're thinking about risk of healthcare associated transmission. Next slide, please. So I asked some various friends. The people who answered were mostly in California. And right this minute, I don't even remember which hospital is which, but I'll say there's one that doesn't differentiate between peds and adults in terms of their protocols for infection control. All the kids get put into airborne isolation and they come out of airborne isolation with the same sort of protocol, which would generally be 3 smear negatives, and usually a couple weeks on effective treatment. Another children's hospital puts kids, at a baseline into airborne precautions. They limit visitors to the immediate caregivers, and they specified that those caregivers, those allowed visitors, when they're out in the rest of the hospital, they have to wear a mask until they're cleared by the infection control practice team, and that the discontinuation of isolation is made by infection control. Another children's hospital limits airborne precautions needs to kids over 12, and having smear positivity or laryngeal, and then babies who are suspected of having congenital TB. Again, they say parents and other family members must mask outside the room, but they didn't specify to limit the number of visitors. And then finally, the last person who answered my email said that they use airborne for all children suspected of having pulmonary or respiratory tract TB. Only 2 family members who are essential to providing support can come. They have to start their screening for TB during that time frame. Visitors have to mask in the room, and that the isolation is discontinued when the decision of the attending physician and infection control determines the patient's non-contagious. Next slide, please. So this is your biggest and most famous children's hospital in Washington, and I'm paraphrasing the policy, which, by the way, they are updating. So I know that at least Dr. Yazzie and maybe some infection preventionists from that very famous children's hospital, where Russell used to visit, and now he visits now that he's in Pittsburgh at my alma mater, Children's Hospital Pittsburgh. Anyway, they isolate all children with suspected or confirmed pulmonary TB, regardless of age. The caregivers undergo screening with chest radiograph, which I love. Because that's the only way really to know. It's amazing how many family members say, no, I don't have symptoms of TB, and they're suppressing a cough during your whole visit. And then they keep the children in isolation even after the caregivers screen negative. And they have release from isolation protocol requires effective therapy for 14 days, clinically improving or at least not worsening. And then for extrapulmonary TB, we know that children certainly can have exclusive extrapulmonary TB, but sometimes they also have pulmonary TB. So they use airborne precautions kind of while you sort that out. And then even after they've ruled out pulmonary TB, they use their airborne precautions during procedures that might involve that extrapulmonary site. So if you're going to, for example, go to the OR and wash out a wound or something like that. Next slide, please. So this is what my preference is when I have input into the Children's Hospital's protocol. What I like to do is put all kids who are suspected of having TB disease in airborne precautions. And again, when they undergo AGP, for sure, and I include gastric aspirates for that. I like to also hopefully have only 2 family members who are allowed to visit the child, and that they are in the process of being screened for TB. And then the visitors who have previously been exposed, this is a passion of mine throughout all of infection control, not just about TB. But if you're going to have visitors who have not previously been exposed, those people have to be treated the same way healthcare workers. So they have to wear PPE just like healthcare workers would. But in this case, most of the time I'm just allowing the parents, and they've already been exposed, so I don't insist that they wear a mask in the room. And then though, if I'm going to let that kiddo out of isolation, I need to make sure that the parents or those two family members who are in the process of being screened, that we know they don't have TB disease, because that would be a nightmare and is sort of not uncommon. But once all those things are done, once the kiddo is done getting their gastric aspirates or their sputum induction, the family's cleared. If they have the classic X-ray findings in childhood, which does not include cavitary disease and usually, honestly, is not very extensive, then I recommend decreasing or discontinuing the airborne precautions, because again, people are more likely to go in the room, they're more likely to interact with the family, and also oftentimes those airborne rooms, those negative pressure rooms, are needed for a different patient. So that's what I like to suggest. And I think that is my last slide. And again, we have representatives. This is just, I'm basically saying what I said before.